everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and families to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm a proud mom of a preemie and a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also very well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, I invite you to head over to canadianpreemies.org. That's our website. And there you will find many resources which are free for you to use for yourself and your unit, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so I invite you to please bring your voice to the table. Let us know where you're watching from. Put in any comments you have about what you see or any questions in the chat, and we will try to address them at some point during the program today. It is through rich conversations like these where we can advance practice and learn together. So please participate, and it's always very interesting to see where people are watching from, so please let us know. Today's topic is always, I'm going to say, a hot one because it is often that last piece of the puzzle that families need before they go home. Today, you guessed it, we're going to be talking about learning to feed your baby in NICU. We're going to talk about recognizing feeding cues and disengagement cues, and also how families can participate in transitioning their baby from gavage feeds to breast or bottle feeds in NICU. As you know, feeding is always a team effort, especially in NICU. It can take a whole team to make the dream work. And to lead us in the discussion today, it just makes sense that we have two members of the healthcare team. You will probably meet while you're in NICU, a neonatologist and an occupational therapist. Jessica Duby is one of our speakers today, and she is a neonatologist at the Montreal Children's Hospital and an assistant professor in the Department of Pediatrics at McGill University. Her research and qualitative improvement work focus on how families and healthcare workers can collaborate to improve neonatal outcomes in resource-poor and resource-rich settings. One of her current projects includes a quality improvement initiative to involve parents in their baby's transition from gavage feeds to breast or bottle feeds in the NICU. And she will be joined today by Christine Labelle, an occupational therapist, also at the Montreal Children's Hospital. She has spent the last 19 years working on the Neonatal Intensive Care Unit and within the Neonatal Follow-up Clinic. She is GMA Advanced Certified and has completed her certification as an international board-certified lactation consultant. She's involved on a multidisciplinary team where she has developed a specialty in the evaluation and treatment of infants with complex feeding difficulties. So thank you both for joining us and welcome.
Thank you for having us. I will say, Leah, we've had, when we were listening to you, it was cutting in and out. So I hope our connection will last throughout the Preemie chat.
I hope so too. I'll put your presentation up and let you get right to it.
Wonderful. So I'm Jessica and this is Christine. First, we'd both like to thank Leah and the Canadian Premature Babies Foundation for giving us the opportunity to discuss the topic of transitioning from gavage feeds to breast or bottle feeds. And second, for any parent who's listening, I do want to emphasize that going home with a nasogastric tube or a gastrostomy tube should not at all be seen as a failure. Each patient is a unique baby with unique strengths, and what we talk about today may or may not be applicable to your specific child in the NICU. In fact, there's actually many European and African NICUs that routinely discharge babies home with the nasogastric tube, and the expectation is that transition to breast or bottle feeds happens at home. So Christine and I are going to present some slides together. I do want to let you know we had hoped to show part of a video that we made, which unfortunately doesn't seem to be working, but I think Leah is going to pop in the YouTube link in the chat section, and we will also show the QR code that you can access at a later time. So first of all, we have no conflicts of interest to disclose. We did receive a grant from our Department of Pediatrics to do this initiative. And then I also want to thank all the wonderful parents, families, and patients who agreed to be our actors and actresses in the photos and videos that you will see. So the transition from a tube, which can either be, nasogastric, orogastric, or even a gastrostomy tube, which together we can call as gavage, going from that to either breast or bottle feeds is often a very important step to getting out of the NICU. And the evidence actually shows that it's a key determinant of a length of stay for many babies, and obviously a very important thing for many parents, as this is something that they're going to have to learn how to do when they go home. So most NICUs in Canada use one of two methods currently to help the babies transition from gavage feeds to breast or bottle feeds. The first one, which is actually what we used to do at the Montreal Children's Hospital until quite recently, is on the daily medical rounds, the doctor will prescribe the start and the progression of breast or bottle feeds based on their kind of overall assessment of the baby. So an example prescription, which actually comes from one of our charts, might say offer the bottle 5 to 10 milliliters as interested during each feed. The other approach that some NICUs are using is what's called in the literature infant-led feeding. And what this means is that the nurse at the bedside is continuously assessing the baby's feeding cues, and based on their cues, the nurse is telling the mother or the father how much and when to breast or bottle feed. And actually, they've shown that this infant-led feeding is a better approach to the doctor-led one because it results in the earlier achievement of full breast or bottle feeds and therefore the earlier discharge of the baby. Before we go any further, I think it's important, and Christine will talk about this a bit more later, but what do we mean when we say feeding cues? And this is actually comes from a poster that's in all of our babies' rooms who are making that transition. So feeding cues are things that would tell us that a baby is ready to have a breast or a bottle feed. So things like, I don't know if you see my cursor, but waking up, moving, sucking on a pacifier, bringing her hands to her mouth, the baby turning their head and opening their mouth, or being alert and fussy. So that might tell us when a baby is ready to try breast or bottle feeds. But just as important are what we call signs of disengagement. So this is when the baby is actually feeding, either by breast or bottle. What are the signs that you should look for to tell you that the baby is ready to stop breast or bottle feeding? So examples of that might be that the baby pushes away the nipple, they're falling asleep, they may even gag on the nipple, they might slow down or stop their sucking completely, or their tone might become a little weaker, kind of like a little bit of a floppy baby. So if we go back to the traditional approaches that we talked about to making this transition from gavage feeds to breast or bottle feeds, we said that the infant-led feeding, where the nurse assesses the baby's cues, is kind of a step up from the doctor-led approach. But even the infant-led feeding has a problem. And the big problem for both of the approaches is that neither actually engage the families, who are the ones that need to learn when and how to feed their baby when they go home. So we at the Montreal Children's Hospital had a multidisciplinary committee that included myself, Christine as an occupational therapist. We also had nurses, a nutritionist, and a parent representative to design a quality improvement initiative that we call family-driven feeding. And this is a pretty new initiative that really just started this past spring. So what is family-driven feeding? It's very similar to infant-driven feeding, but now the focus is not so much on the nurse assessing the baby's cues, but now the focus is on the nurse teaching the families how to assess whether their baby is ready to breast or bottle feed, and when they are breast or bottle feed, what is the quality of that feed? And this little sort of chipmunk is a sign that's on every baby's door who's participating in this program, so that every healthcare professional is aware that the baby is working on this transition. So what we did was we took a lot of the scoring systems that are used in infant-driven feeding, and we got parent feedback and basically simplified the infant-driven feeding scoring system so that parents could also participate. So who gets to participate in family-driven feeding? So first, the doctors and the nurses have to decide that it's safe for your baby to participate. We wait for the baby to be at least 32 weeks corrected gestational age. We want the babies to be either on room air or low flow oxygen, so not on things like CPAP or high flow nasal cannula. I do know, and I would really be interested in hearing during the discussion phase, that there are some NICUs that actually feed babies who are stable on CPAP, which is not something that we have traditionally done at the Children's, but I know has been tried at other places. We also make sure that the baby's overall stable. So when the nurse or the mother is touching the baby, make sure that the baby doesn't stop breathing, their heart rate doesn't go low, or their oxygen doesn't go low. They obviously have to be able to tolerate the feeds that they're getting by the tube. And the medical team overall has to say that this is an appropriate program for the baby to participate in. So for example, babies that are very, very weak, which we call hypotonic, or babies with perhaps anomalies of their face, may not participate in this program, even if they meet the other criteria. So I'm going to pass it over to Christine, who's going to talk a little bit about what it is that we teach the nurses and the families to do.
Mm-hmm. So once the medical team, the nurse, the family is on board, everyone feels the baby is ready for the next stage, for the exciting phase of starting to feed by mouth, the nurses will always accompany the parents initially into teaching them how to use the tool, but also how to read their baby's cues, both in the readiness and the quality of the feed. So the tool that we've developed, like Dr. Duby mentioned, we've simplified it so that we all use the same kind of language and vocabulary, and we all look at the same things. So we can all agree that when the baby is ready to be offered a bottle or a breast or not. So we've developed in the readiness kind of scale a score of 1 to 4, 1 being the most mature kind of response when the baby wakes up on his own, is alert and fussy during the care, turns the head, shows a lot of cues in a sustained kind of way. A score of 2 if the baby, needs a bit of prompting to show those cues or may not show them for a very long time and may be a bit more sleepy. A score of 3 when the baby briefly gets alert during the care or just stays asleep during the care and shows very minimal to no feeding cues. And of course, a score of 4 if the baby's physiological stability is not optimal. And then we're gonna have actions related to the score. So a score of 1 or 2, the baby could then progress to be offered a breast or bottle. And a score of 3, we would only encourage putting the baby in skin to skin or be offered the breast but no bottle. And of course, a score of 4, the baby will need gavage at that point. So if the baby scores a 1 or 2 and we do progress to oral feeding, we will then proceed to offer a breast or bottle to the baby. We like to encourage breastfeeding as much as possible, so we will always kind of follow the lead of the families. If their desire is to breastfeed, we will follow that lead and try to really protect the first feeds at the breast for as long as it's working out for the baby and the family. So breastfeeding will always be prioritized. In regards to the quality of the feed, we developed a score of 3. So a score of 1, again, the more mature kind of response. Sorry, I'm thirsty. That's okay. And we developed kind of different descriptive depending on the breast and bottle, given that the skills are a bit different and the things you're looking at are a bit different in order to score the quality. So the more mature response will have a more coordinated, mature, sustained pattern of sucking. A score of 2 would be a baby who's still kind of learning this whole suck, swallow, breathing pattern and needs a bit more support during the feed, or may fall asleep more quickly and not have as much of a sustained pattern. And a score of 3 would be if the baby is really not quite efficient at the breast or bottle, or cannot actually coordinate safely or maintain physiological stability. And then at that point, we would always follow the baby's cues to know when to stop feeding. So if the baby scores a 1 or a 2, manage well, we're going to keep looking at the baby throughout the feed. And when he shows signs of disengagement, like Dr. Duby mentioned before, then that would be our cue to stop feeding. Of course, if the baby is not physiologically stable, we would stop immediately. And then we ask the parents to kind of give us the information, and also for them to kind of document how things are going. So they're going to write the time of the feed, who did the feed, whether it's a nurse or a parent. They're going to give us the readiness score, the quality score, and they're going to give us the details of the strategies that were used also that we didn't include in this PowerPoint, but whether they fed the baby in sideline position, whether they used a specific nipple, whether they offered pacing during the feed, it's all going to be specified. We're going to know what nipple was used, whether the breast or a different type of bottle nipple, how long they fed for, how much, and then they're going to sign, and we're going to ask the nurse to co-sign as well. We really try also to normalize that, we can start scoring very early, and we may score babies who are not ready to feed for several days, several weeks sometimes, and we really try to normalize this and encourage the parents to keep doing it, because that's going to allow us to really see when the baby is ready and kind of catch the proper time to start feeding.
Great, thank you, Christine. So as part of this new initiative that just started in the spring at Montreal Children's Hospital, we had a multi-pronged educational approach. So first, we actually had to teach the nurses how to be able to assess if a baby was ready to breast or bottle feed and their quality of feeding. Because if you remember, before this initiative, the nurses really relied on the doctor's prescription that would happen every day at rounds. As part of teaching the nurses how to do the assessment, the nurses were also then taught how to teach a parent to assess the baby's readiness and quality of feeds. So as part of the educational initiative, we created an 8-minute video that's really for parents and nurses that's publicly available on our hospital's YouTube website. I think this is the one where I wanted to show you 2 minutes of it, and unfortunately we weren't able to get it to work. You can use the QR code. You can just go to the YouTube and type in Montreal Children's Hospital, or I think Leah is also going to put down the English and French YouTube link for this. So parents and nurses are encouraged to watch the video. And then, you know, on top of the video, what's probably even more important than the video for parents is that really that bedside nursing teaching. And I will say at the beginning, it's quite intensive for the nurse, but we found that our nurses feel that if they put in the good work at the beginning of this transition, then their workload will decrease sort of later on as the family takes more ownership of transitioning their baby from gavage to breast or bottle feeds. So again, my apologies that we're not going to be able to show it. So how is it going? So the initiative is very much still in its infancy, and like with any new project at a NICU with a whole culture change, there's going to be successes and there's going to be areas that need some improvement. So since the spring, we've actually managed to train the majority of nurses on how to assess babies' feeding cues and how to then train the parents. And this was done with Christine and other members from our committee who did 1-hour teaching sessions with the nurses. So when we look at our current data, what we're seeing is that on average, parents usually fill out the assessment form about 1 to 2 feeds per 24-hour period. You know, I think our goal is to try to get up to 3 feeds a day, and the rest of the feeds are being assessed and scored by the nurses. What's really nice and reassuring is that we found when the parents do the assessments, their error rate or mistakes are less than 6% of the time, meaning that it's something that parents can pretty quickly learn. As part of one of our PDSA cycles at the beginning, we went around and talked to 20 parents who had been taught family-driven feeding. And those who had been taught, the majority had then gone on to complete at least 1 assessment. And only 3 out of the 20 parents identified any barriers in order to participate in family-driven feeding. So what are the next steps? And this is where also we'd invite you to give your suggestions. As I mentioned in the previous slide, what we're hoping to do is increase the percentage of feeds that parents assess. So right now they're usually on average doing about 1 to 2 feeds per day. Our goal is to then see, can we get more like 2 to 3 feeds per day? And we're sort of have an ongoing discussion and collaboration for how we're going to do that. But we'd love to hear from anybody in the audience who has ideas. And then eventually what we want to do is we want to compare the outcomes of babies who participate in family-driven feeding to the outcomes of babies that were in our NICU before we started this initiative. So does family-driven feeding actually make a difference? Do we start breast or bottle feeds earlier? Does the length of stay go down? Does the time to achieve full breast or bottle feeds change? So I think that's going to be really where our, bang for our buck is to see whether it changes outcomes. So in summary, hopefully we've shown you that achieving full breast or bottle feeds is a key factor in determining when a baby can be discharged. That starting and advancing breast or bottle feeds based on the baby's cues, whether it's the nurse that does it or the parent that does it, actually results in earlier discharge rather than relying on the doctor to decide. And that involving families in assessing their baby's readiness to start and advance breast or bottle feeds is really important, because at the end of the day, it's the family that has to take this baby home. And that we at the Montreal Children's Hospital are trying to find a way to get families involved in that assessment of the baby's feeding cues, and it's an ongoing initiative. So my son, who's 3 years old, is currently obsessed with Dr. Seuss. And so I thought this quote was really nice as it relates to family-driven feeding, which says, "You're off to great places. Today is your day. Your mountain is waiting, so get on your way." So we've had a lot of successes, but we definitely still have a big mountain to climb. And we're open to any questions or suggestions that the audience may have. Thank you so much.
Your mic.
Leah, your mic is muted.
Thank you. Thank you so much for your presentation. I am going to leave that slide up just for a minute so people can take down your contact details. And I did put both the English and French link to that video in the comments. So I encourage everybody to check that out. I think I want to commend you both, first of all, for seeing something that could become this whole new initiative on its own. I think oftentimes we see a problem, I'll say problem, like feeding in NICU, or a challenge. And this seems like a very innovative way to try something different. And so why are you both passionate about this?
You want to go? Yeah.
I was gonna say, for as an occupational therapist on the NICU, feeding is a multidisciplinary kind of approach. Everyone, like from nursing to parents to the medical team, everyone has their vision, right? But as one person in the NICU, it's hard, like, to do this teaching to the parent, and there's so many people involved with the baby. So having kind of a tool that everyone's using the same words, has really made a difference. So I feel in the work that when I come now with the family, like I see they have much more knowledge already than before, and that's really encouraging. So I think for a long time I felt like I was doing this job a bit alone, and to have like now a team approach really makes a difference for the families. And like you've mentioned, feeding is so emotionally kind of hard for families, because they've gone through so much already by the time they start feeding, and they just think it's gonna be easy. That part, that's the easy part, is to learn feeding. So it's always a shock for a lot of families when they realize how long of a process and hard of a process and how frustrating it is. So I think, yeah, if we can improve things a little bit, that's great.
Yeah, I guess for me, so a lot of my other research or QI is really related to families, both in Canada, and I do a lot of family integrated care in Uganda. And it keeps coming back to, if you want to make change in terms of length of stay and how long that baby's in the NICU, it really comes back to, at the end of the day, can that baby feed? Or how are you going to assist that family at home learn how to transition from gavage to feed? So it was interesting to see how important that is to families, more than some of the things that we as medical professionals might think are important. So for me, it's really coming back to what matters most to the families.
I love that. We do have a question from Deanna, who's watching. She said, with this approach, how do you determine NG top-up amount with breastfeeding? Is there a guideline you follow?
Yes, we did develop a guideline for that. So here we've decided to do pre and post weight checks. We won't necessarily do it from the first feed. We'll do it when we start seeing kind of more nutritive sucking at the breast, so more of a score of 2, depending. And we have given education to our nurses so that it's being done correctly. And then we also teach the parents to do it. And it's worked well.
Yeah, and I guess I'll add, so, Christine talked about how at the beginning we don't do that when the baby's just starting to learn. Similarly, we also want to try to not rely too much on it. So there's that middle period where we use it, and then for the mother to kind of learn, what does it feel like when the baby's, taking a full breast, not a full breast. And then we actually try and transition away from pre-post weights and kind of use the mother as a guide. Yeah, I think we need to top up about half, or nah, he really didn't take anything. Why don't you give him the full mg?
So transition for the family is to like counting every ml when you decide their baby makes it small and every ml is counted, to kind of letting go of that control. So it's a transition. Yeah.
I love that you're saying that you ask the family. Again, it's that, do you think baby needs a top up? I love that, kind of allowing families to weigh in on that, because that's something that, again, I think feeding is an art and a science. So you do have a bit of trial and error in there when you're trying to, like you said, hit that window of what is enough for our babies. And they tell us too when they're still hungry. I'm just wondering, the hour teaching that you did with your staff, I noticed that you said you went around, you did an hour of teaching, and that was enough to get this initiative rolling. So was that something that you did like at the bedside? Did you block off an hour of time? Because I know that's something that, it's always difficult to get education in, especially an hour is a lot of time and it's a lot of information. So how did you go about doing that?
So I'll give you the sort of behind the scenes look, and then Christine will tell you about the details. The behind the scenes look is we were privileged, again, like I said, to get a grant from our department. So we gave nurses $50 Amazon gift cards to attend a 1 hour session, right? And we fed them.
Wow.
On top of it. So food and money is, very helpful for starting any new program. But it was Christine and her group who actually did the teaching.
So we did have to take into consideration that we were asking the nurses to spend their lunch break with us. That's why we kind of offered to pay their lunch break, basically. And that's kind of how also we only add 1 hour, and we did have to fit a lot of information in 1 hour. It was enough though to kind of give a good baseline, considering the nurses do have a baseline kind of knowledge of feeding and experience. But we still kind of managed to go over not just the tool and how they were going to teach the families, but really get into more of the knowledge of the feeding development and what suck, swallow, breathing is, so that everyone was kind of on the same page in regards to what is a normal feed, what are we worried about, when is it time to call for an occupational therapist, when things are going well, and when we should be worried. So we did cover a lot. And I think otherwise it's kind of ongoing education. So we continue to support the nurses. We may do a bit more kind of refresher teaching and so on, but it wasn't enough. But we have almost 200 nurses on the unit. So over the course of 2 weeks, we gave a lot of sessions, both at night, during the day, and
a virtual
online.
option.
Yeah.
And then, so I think what Christine kind of mentioned is it's ongoing education. So for example, right now we have a little pop quiz raffle for the nurses of Spot the Air. So we put on, the documentation form, and we make some mistakes on the form. And then we're asking the nurses, what is the mistake? So it's that kind of ongoing little sessions of teaching. But really, like Christine said, at the beginning, we just got that good hour from them. And now it's finding little times at the bedside.
I love, again, even in your educational initiative, it's creativity and thinking outside the box. And it sounds like you're really working toward engagement, which you really do need good, solid engagement in order to bring about a change like this. So congratulations on that. Do you see this as something that can expand? Like, what are your plans for the future? Will there be opportunity for different sites to take part and then also document and keep that data?
Yeah, so I think what's interesting is, and I know this is different for different NICUs, but what happens to our babies? So a third of our babies go home straight from our NICU. A third of our babies actually transition from the NICU to our hospital pediatric ward. So they're not ready to go home, but they need some, maybe even occupational therapy. They need some specialized therapy that we like to keep them within our hospital. And then the last third, we are considered a level 3/level 4 NICU. The last third, we actually transition them to other hospitals that are level 2s. So I'll let Christine, because she also does wards, and I think that's our next step, is to get our pediatric ward team on board with us.
Mm-hmm. So in the NICU, we do a lot of initiation of that feeding, and then a lot of our babies get transferred to the ward to kind of get that tube out and kind of progress to this more on-demand kind of feeding schedule. So very early on, when we developed this project, we communicated with the wards and made sure we would transition. So we do all this teaching to our parents when they get transferred to the wards. We want them to be able to bring kind of that same kind of tool to the wards, and then they can work on that. They are like already developing their own kind of system, more focused on transitioning off gavage. So that's kind of an ongoing
and
project.
then the other thing that we've started to do, which is really just the beginning, is any baby that goes to a level 2 who had participated in this program, we send with them kind of a letter to the doctors explaining what the program is. They might not do it there, but at least, you know, that the parents have been involved. And I think my dream, because we have part of our NICU group that does outreach to our level 2s. And so my dream is, once we've mastered how to do this family-driven feeding, is to make it part of our outreach program to our level 2 NICUs in our community.
That sounds awesome. And I love that, if nothing else, the communication is getting out there, because I know it can be difficult for people to switch hospitals or switch units when they've experienced something and it's different somewhere else. And especially something like this, where you've really given some power over to families, then it can be hard to then be in a place where it's not the same. So kudos for you guys. I'm wondering about how you get around the challenge, and maybe you don't, but of the medicalization of feeding. Do you find that this has helped or hindered that whole idea?
So I guess I'll answer that as coming from my faculty group. So if you remember, before this, we weren't even doing what's called infant-led feeding, where the nurse says. It really was the doctor that had to say, yes, this baby can go to the breast for 10 minutes and only 10 minutes. So it's been also a huge culture shift for the doctors. And I think almost what we're seeing is, and this is probably an ongoing challenge, is the pendulum has actually swung a bit too far, because now our doctors are like, oh, family-driven feeding will take care of everything. And so they prescribe it and forget that they also have to have ongoing involvement, or perhaps it's a baby, like we said, that's very weak, called hypotonic, that may not be appropriate for family-driven feeding and should have, you know, somebody like an occupational therapist involved from the beginning. So it's, you know, I think it's with everything in medicine. You start from one side very extreme. Sometimes you end up on the extreme on the other side, and now we're going to try to bring them back to the middle to see where family-driven feeding is appropriate.
I agree. It's an ongoing adjustment.
Yeah.
For everyone.
And do you have any preliminary data about the success of the program or feedback from families?
Yeah, so I think we had a slide on that. So in terms of what's actually happening, so we're finding that parents participate on average in 1 to 2 feeds per day, which, again, anybody in the audience, if you have good ways to help us increase that level of participation. And then we did poll, and we actually have an ongoing poll, but we polled our parents a month into the program to try to identify barriers. And there weren't that many that identified, but some of the barriers were things like the time it takes. Mm-hmm. The other barrier that was interesting was experienced parents felt it was, I don't think the word is belittling, but like you know, if they've already had 3 children, even if it's term children, I don't need this. I know how to feed my baby. So that was an interesting thing that we haven't really considered, a first-time parent versus an experienced parent, and how to perhaps approach those families differently.
And so will that be something that you adjust as you go along?
I think so. We can add it to the long, long list of things that we have to tackle with the program.
I think it's very
our parents are
Yes.
receptive. It's not just
Correct, right.
Yeah.
So at the beginning, we polled 20 parents after the first month, and really only 3 of those 20 identified barriers. And we're currently in the process of polling. Now we started in April, so we're almost 5-6 months into it. I can't do math, but we're polling another round of parents to see where we're at.
I love that. I know I've said it multiple times, but the whole initiative, the whole idea of, even down to the title, the family-driven feeding, I think it's tremendous. And so I wanted to thank you both for sharing your wisdom. And I do hope people check out that video, because I know I'm a video person and a visual person, and I'm sure it's wonderful. So I apologize we couldn't get that up and running today, but kudos to you both for thinking outside the box and for coming up with this, and then for sharing it with us today. I've seen in the comments we've got lots of, especially healthcare providers today, watching this one. And so I think people are interested in finding these solutions that can help families get home sooner and feeding by their choice. So thank you so much for joining me today and for sharing.
And again, thank you for inviting us. I think you had put up our emails, but please, if anybody is interested, we're happy to share our tools, and we're happy, again, also to take your suggestions of what you're doing in your NICUs that seem to be working.
Thanks again to you both. And thank you, everybody, for watching this edition of Preemie Chats. A special thank you to AstraZeneca for their ongoing support of educational programs such as this one. Just a reminder that if you missed any part of today's episode, or if you want to look back on past episodes, then you can visit CanadianPreemies.org. And on that website, you'll see this episode, all our past editions. There's over 300, so a variety of topics there. You'll find many resources and support. And you'll also be reminded that CPBF is a charitable organization, and it depends on support to continue its mission of empowering families of premature babies in every step of their journey. So consider how you can fit in to making that a reality. Together, we can make a brighter future for NICU and preemie families. Join us here next Friday at 1 p.m. Eastern Time, and we're going to be talking about outcomes of children born extremely preterm. And this is about a project that is extremely important. It's called the Parent Voices Project, so you won't want to miss that. Hope you're able to join us then. In the meantime, have a great weekend, everyone.